Using the BNMS YouTube channel, we're here in the very heart of the bustling conference, and we've just finished our neuroendocrine tumour session, and it was an immense honour for me to invite these prestigious people who've been treating neuroendocrine tumour for many, many years. And we've got Professor Martyn Caplin. I'm going to say Professor Amy Eccles because it will happen quite soon. Professor John Buscombe and Professor Tahir Shah. My joke at the minute is that if you see someone in a suit, call them a professor, and if you see someone on the stage, call them a president. And this is you keep yourself quite good at this conference. So I'm going to start off with you, Martyn, John, because you and Martyn set up the first integrated neuroendocrine tumour clinic. Was it in the world?
No, I think we were following the Uppsala pattern, weren't we, which has started sort of looking at this. And I think there are people having the same idea in multiple areas that realising you needed more than one medical specialty working together. And I think it was this recognition that we have seen patients coming from all different angles who had all been partially treated by somebody who had a little bit of knowledge. And what we really need to do is combine those bits of knowledge together to provide a much more holistic approach to treatment. But maybe Professor Caplin could also say something on that.
No, I agree. We weren't to the first. I was copying what was going on in Uppsala to a large degree in the 1990s. I think what struck me at the time was I was working at the liver unit at the Royal Free Hospital with Andy Burrows. And Tahir, you were in fact a registrar in those days. We had Melanie, if you recall, who came and she had metastatic neuroendocrine tumour. She was aged 24. She'd been sent to a psychiatrist with a diagnosis of anorexia. And I just felt the complete injustice of this whole process for the patients who'd been sent all over and had been given the wrong diagnosis, and it's still the case that it may take 3 or more years to get the right diagnosis. And it was that sense of injustice that drove me in terms of helping set up the clinic, and also the importance of this whole multidisciplinary approach as well.
Absolutely, yes. And I've got some questions here that I took during the session. So if you'll go and see the downloaded session, you'll see what I'm talking about. But you started to talk about nutrition and nutritional support, and I know this is a big thing for Tahir. And now you talk about a crucial patient to you who was presented with weight loss. So can you just mention a little bit about the nutritional support and the things that we need?
Yeah, I mean, we manage some of the most difficult patients, particularly when patients present late, and if they present with heart failure or develop heart failure during follow-up, you find that they really struggle with nutrition, and it determines then what treatments they can have or whether they simply get palliated. We found early on that actually, using the liver experience when we were providing a great deal of nutritional support, including nasogastric feeding and turning people around, that perhaps we should take a similar approach to some of these advanced neuroendocrine tumor patients. So we were lucky enough to get funding for a whole-time dietitian who's really allowed us to develop some fantastic services for patients with heart failure and also patients with intestinal failure, to the extent that these patients who will be palliated are now having advanced surgical treatments, and they're having parenteral nutrition and staying alive for many years rather than for a few months.
Yes.
I'm just going to go off on a little tangent, but I think it's so topical because today in the news they're talking about the microbiome as well, and all of that, and how microbiome can impact not only in terms of nutrition but also outcomes for immunotherapy and other cancers. But we've got a prospective study looking at microbiome in PRRT patients as well, to see if that has an impact. And I think it's another fascinating area. But you're right, Tahir. I think the whole question of overall nutrition, BMI, if you've got a low BMI, your outcome tends to be worse than patients with a better
Absolutely.
BMI.
And now, everyone, I am here, but slightly off camera, so you can't admire my beautiful suit, but I am here. And I'm going to ask him, because this is about imaging, and we're really grateful to have the clinicians here. But MTV is a recurrent theme, and how we deliver, I'm asked to deliver routine MTV for my lymphoma patients, and I fail, for my lung cancer patients, which we discussed yesterday, and I failed. And we really need to push for this to be able to be doable, reproducible, and simple, don't we, Amy?
Absolutely, and I think within my talk I highlighted that these patients often have quite a high tumour volume, which will in turn mean that you have lots of regions of interest that you want to draw around, and automating that process can only improve both our quality of life in terms of radiologists, but also in terms of patient quality of life, and giving the clinicians the information they need, stratifying the risks, working out what treatment options we have. We know that neuroendocrine patients are a broad church. They have a lot of different issues, but they potentially also have a lot of different treatment options. But finding that order for that individual in front of you in clinic is important and necessary. And if we have this sort of volumetric information, we can look at that in terms of baseline, but also in terms of response assessment, knowing when to change treatment, knowing when to continue or re-challenge. It's going to be really important and really exciting.
And again, this came up yesterday, and I'm sure it'll come up again and again and again. It's the importance of the MDT, the MDT, the MDT. The revolution from the cancer plan from Stephen Donaldson was the MDT. It is the persistent finding. So I want to ask everyone about what they see as this integration of FDG and dotapeptide. We're writing a review with Stefano Fonti, who's here today, about a possible role of FAPI in PET. So then we'll have triple tracer imaging, and I think this might be the theme for the BNMS next year. I haven't quite decided. So what do we think about earlier and earlier use of both of these tracers?
I think the important thing to remember is that neuroendocrine tumours are actually a heterogeneous group of tumours, and they're heterogeneous within the patient as well as between patients. So I think Amy is right. The more information you gain, as early that you gain that, the more the decision you make can be tailored. But also, I think the important thing is it's not a once and forget, because these tumours change with time, and they will change with treatment. So if you're attacking the somatostatin receptor positive cells, there's a logic. If there are cells that are escaping that because they don't have somatostatins, they will come to the fore. So you get a clonal selection. So what you need to do is to keep in your head through the MDT to reassess. And that may include imaging, it may include rebiopsy. And I think the more tools that we have to do that, the better. But it needs to have the knowledge of when to use them, because obviously we can't do everything in everybody. But I think we all agree that when things aren't following the pattern, things are going awry, think again, what other information do I need?
Absolutely. I mean, I think neuroendocrine tumour is a model for the multi-speciality and multimodality imaging of other tumours. We all need to get, Martyn or Tahir, you must be seeing earlier and earlier use of FDG and things. Say something about imaging, Tahir. Go on.
Well, we certainly are benefiting from ease of obtaining multiple different PET scans for our patients. So 5 years ago, it would have been very difficult for us to propose doing DOTA PET imaging and FDG PET imaging at the same time. But it's becoming more accepted thanks to people like yourself, Simon, and support that you've provided us and the guidance that you provided us. And that's the benefit of having regular input from a nuclear medicine physician, that we have new insights and new evidence seeping into the MDT decision making, and it's been useful in helping us decide which pathway we take our patients in terms of treatment, PRRT versus chemotherapy.
And I'm going to ask Amy to talk about the same-day dual imaging, which I think is going to be a big thing. I can tell you, Tahir was skeptical until he found out that we now have funding for total body PET, and now he's an enthusiast for same-day imaging. So tell us about this, because again, just a little thing. Yesterday we talked to a lung cancer oncologist about they've taken the breast cancer model to the lung cancer model. So the one day where you see the clinician, you review the pathology, you see the imaging, you do extra imaging the same day. So this starts to open up very interesting commitments for nuclear medicine to actually, instead of being in some ivory tower sending out a report, we may actually have to sit next to Tahir and Martyn, God save us, and actually possibly even meet the patient, which terrifies me to death.
Well, absolutely. So I think particularly with the large axial field of view PET CTs, we can bring the doses down. We can bring the timing of scans down. So again, patients who previously maybe weren't able to tolerate a 30-minute scan, particularly thinking about those patients with heart failure, how do you lie them down for that period? How do you help them get those imaging, those studies done? But if we can get this multi-tracer imaging contemporaneously or simultaneously, almost effectively, then again, it cuts down that time for that patient. And if they've taken 4 years to come to see Tahir or Martyn or any of our other sort of patient-facing special colleagues, then actually waiting another 3 weeks to get another scan can feel like a lifetime. And if in the meantime you're waiting for that potential treatment to start, again, it feels like a really long time. So if we can try and get those patient sort of points and those sort of bottlenecks relieved, then that's great. There is obviously the caveat that with that additional information you get, you're potentially opening another option and sort of opening up that multidisciplinary discussion, because there won't be necessarily a clear-cut right answer, and it will absolutely generate more work for us as radiologists and imagers, but that's really exciting for our new future generations coming through.
Absolutely. One of my cheap repeated phrases is that all is judgment and nothing is measurement in medicine. So Martyn, you were going to say something?
Yeah, only you were going to see more of this question of discordant disease between with the FDG positive, a few of those FDG positive, mainly somatostatin positive, but additional somatostatin negative and FDG positive. How we manage those patients? Are we going to end up doing more in the way of combination therapies with PRRT? And these are the areas, in fact, that we're going into now in a practical way, which I think is quite difficult to manage these patients.
And I think that's the thing. I think, again, it's treating each patient as an individual, which is sort of against maybe some of the nice guidelines that we have, that it needs to be evidence-based and we need to have randomized, controlled, double-blinded trials. You can't necessarily do that in such a rarefied patient population where not everyone, just because you say you've got a neuroendocrine tumour, means very little to us. It's a bit like saying you've got prostate cancer. That can mean a lot of things, or lung cancer even. Patients behave in different ways. Tumour populations, cell populations within each patient will behave differently. And I think, absolutely, it may not end up being combination treatments. It might be sandwich treatments that you treat one area first. Yes. You've got all that baseline information in terms of response assessment, working out which bits win in terms of what you're going to target then and now, and working out what those combinations are, and then thinking about the radiomics and the next things about what constitutes... What is an edge? What is response assessment? What is response for that treatment, for that patient? It may not be improvement, it may just be stability, and then sort of working out what your expectations are of the test and of the treatment.
Tahir will say, I say this repeatedly at the MDT, always treat the patient and never the scan. Is that not true? So the scan is just one small component of I'm a great fan of the development of fully integrated diagnostics, where we know where the pathology came from, we know which lesion it came from, we know what that lesion looked like, we know what it felt like, we know what the biochemistry is, and so on and so on. So you can see, I think, neuroendocrine tumour with these people in charge has been a huge success. The prolongation of life and the improvement of quality of life that's been seen over my working practice is astounding. and it's due to people like you, and we're very thankful. Please keep an eye out for the uploading of all these great talks that we had today. We want you to come to BNMS in real life in the future, so please come and see us. Thank you Tahir, thank you John, thank you Amy, thank you Martyn, and thank you for choosing BNMS YouTube channel, and we'll see you soon. Thank you.